قبل أن نبدأ محاضراتنا لهذا اليوم، حقيقة نحب أن نسوي مراجعة للمحاضرات السابقة عن طريق أسئلة، وهاي الطريقة هي اللي تثبت المعلومات ببالكم، وهي اللي تدليكم على المكونات المهمة اللي ممكن يعني تحتاجها في المستقبل، واللي الأسئلة عادة تجي من عندها، واللي أنت تحتاجها أثناء عملك إن شاء الله في المستشفى. راح نعرض مجموعة أشعات ومجموعة صور ونتناقش عليها. اللي يعرف يجاوب يفتح المايك ويعطينا اسمه ونتناقش وياه وحتى نستفاد احنا كلنا. In this X-ray, we see there is a fracture of radius and ulna. من يفتح لنا المايك حتى نتناقش وياه؟ يلا يا شباب. خير. منو؟
السلام عليكم.
عليكم السلام. شو اسمك؟
علي محسن كاظم.
علي محسن. يلا محسن. علاوي راح اول شيء حتى تقرا اشعه بالكسور لازم تحدد هذه الاشعه لطفل او لكبير بالسن، مو صحيح؟
نعم دكتور هاي الاشعه لطفل باعتبار الفيسلز والابيفيزل ما كلش واضحه، كذلك اذا نباوع على الكاربوبونز كذلك تلاحظ انه داير مدارها كهواي فراغ، فهذا ممكن يعني انه هاي كارتليجينيوس بارت ما يطلع واضح بالاشعه، يعني بعد مثلا بعد ممكن مو كلش بالغ، وهي الاشعه عاده طفل.
ممتاز علي، ممتاز، هذا جواب جدا ممتاز. صحيح. سمعوا زميلكم ايش يحكي. زين علي، انت اذا تشوف فراكتشر راديوس وأنا مو صحيح؟ زين شنو هذا البياض اللي داير مدارهم؟
دكتور هذا البياض ممكن داير مدار الراديوس مثلا الكالوسيز او كذا اللي صار مثلا بعد.
فيري جود. هذه الكالس فورميشن، يعني هذا الفراكتشر ان بروسيس اوف هيلينج. ذيس از ذا كالس فورميشن. ابو حسين
نعم،
اريدك تعطيني تحكم لي على الريدكشن هنا، accepted لو نوت.
دكتور نوت اكسبتد. دكتور اذا تلاحظ احنا عندنا مثلا انه الالنا صار به شلون الانجوليشن، فممكن هذا الطفل يعني الريدكشن مالته ما كان كامل ورجع صار عنده ريفراكتشر، يعني هسه مثلا احنا عندنا نلاحظ انه الالنا ما صار عنده كالس فورميشن جويننج لايك ذا راديوس، فممكن هذا ممكن انه الفراكتشر مالنا ممكن يعني هذا شيء ريسنتلي. لو كان الريدكشن كان مضبوط وكان يعني اكسبتد والاينمنت صحيح ممكن يعني ما صار عندنا هالخربطه، هسه تقريبا احنا صار عندنا يعني روتيشن او انجوليشن بالبون.
خوش حكي. احنا هسه علي ايش قال لنا؟ قال لنا احتمال يكون عندنا صاير فراكتشر جديد بالألنا، صح لو لا؟ طبعا احنا عندنا القاعده مالتنا شو تقول؟ تقول بالسكندري بون هيلينج اللي هو كالس فورميشن، عاده الكالس تتكون وين؟ جوا البريوستيوم، سب بريوستيوم، اوكي؟ فاذا الكالس بالالما متكونه اكو بريدج، مو صحيح؟ من الديستال، من البروكسيمال بارت للديستال بارت، اكو بريدج مالتنا نشوفه. هذا اللي داش سهمي ما بالسهمي يمك يطلع له لا. هذا البريدج هو الكالس، وهذا البريدج علاوي ما مكسور، اوكي؟ ما مكسور. لو صاير عنده فراكتشر جديد، صح انت اذا تشوف هذا السهم ده يطلع عليه يمك؟
لا دكتور لا.
ها هذا اللي تشوفه انت يسمونه الشادو مال الفراكتشر، يعني اللاين اوف ذا فراكتشر، لكن الكالس لا تزال موجوده، يعني الكالس موجوده وما مكسوره. فالبريدج هذا اللي متكون هو كالس ما مكسوره، فاذا هذا ما صار فراكتشر جديد. هاي اول نقطه. النقطه الثانيه ابو حسين، احنا عندنا الراديوس احنا ايش قلنا؟ قلنا احنا نريد adequate position، مو صحيح؟ حتى نحكم على ريدكشن. قلنا عندنا نقطتين، adequate position and proper alignment، مو صحيح؟ صحيح. احنا بالنسبه لنا انت ذكرت نقطه كلش حلوه، احنا الابوزيشن هنا اوكي اكسبتد
تقريبا اي دكتور. نعم
ممتاز، لان احنا قلنا 50% وفوق نعتبره adequate position وانتهينا من الموضوع. زين الالاينمنت هنا accepted or not، لانه احنا هذا طفل، والطفل احنا نتوقع يصير عنده ريموديلنج. يعني هاي المحاضره شويه باكر ان شاء الله يمكن الدكتور سعد يعطيكم اياها مال الكالس فورميشن. الريموديلنج بالاطفال كلش هوايه، فممكن يتعدل الكسر اذا كان بديفيشن ميديالي او لاترالي. لكن انت ذكرت نقطه، قلت روتيشن. الديفورميتي الوحيده اللي الجسم ما يقدر يصلحها هي علي
روتيشن دكتور. مهم
فيري جود. الروتيشن يعني علي احنا اذا عندنا شويه رايح ميديالي، شويه لاترالي، شويه دورسالي، شويه فنترالي، خلينا نقول 10 15 درجه، هذه اكسبتد بالاطفال. اوكي 15 درجه اكسبتد بالاطفال، لكن احنا ما نقبل بالروتيشن ولا درجه. مفهوم يا شباب؟ علي
نعم دكتور.
هاي تجيك بالامتحان، هاي تجينا بالامتحان كل سنه. The only deformity that not accepted هو شنو؟
rotation.
Very good, excellent. زين، فإذا هسه هذه fracture radius and ulna in a child with callus formation, the healing is not completed. There is slight malreduction، اتفقنا ويا علي انه اكو deviation. الديفيشن هذا about 20 degree. We expected that this will heal. There will be an element of remodeling. Okay, if مثلا suppose remodeling ما عجبنا او مثلا ما قبل remodeling، نقدر نصلحها. ليش نصلحها بالمستقبل؟
اوستيوتومي مثلا.
Very good, corrective osteotomy. وانت البارحه عرفت الكوركتيف اوستيوتومي اكو نوعين، مو صحيح؟ حتى نصلح العظم.
اوبن وكلوز.
ممتاز ابو حسين، ممتاز. علي ايش؟
علي محسن كاظم.
علي محسن كاظم، شكرا ابو حسين، شكرا. طيب هذا اعتقد قدامكم واضح صار. هذا سولتر هارس كلاسيفيكيشن. من يناقشنا بالسولتر هارس كلاسيفيكيشن؟ خليه يفتح المايك. يلا هو قدامنا واضح، ما بيفت شيء. منو؟ يلا من يشاركنا؟ من يشاركنا بالمناقشة على السولتر هارس كلاسيفيكيشن؟ علي؟
نعم دكتور.
هذه سولتر هارس ابو حسين؟
دكتور نعم سهلة.
سهلة؟
يا الله
يا الله يا الله. علي شنو هذا السولتر هارس كلاسيفيكيشن؟ وين يفيدنا؟
دكتور هذا يفيدنا الكلاسيفيكيشن، يفيدنا اكثر شيء بالاطفال، باعتبار انه يعني نهايه البون مالت الفيزيال بليت والكذا تكون يعني اكثر شيء كارتليجينيوس. لذلك انه الجروث بليت از افكتد اور نوت، يعني في المستقبل راح يتاثر الجروث مال البون لو ما راح يتاثر.
Very good, excellent. علي بتايب 1 احنا الفراكشر باس through the
الحد ما بين تقريبا الكورتيكال وهاركاتيجينس بارت اللي هو تقريبا يقول فد مكان بالبون يكون مثلا انه صار بي اكثر مور كورتيكال او مور يعني يكون اكثر قوي، لذلك ما راح يمر لنا بالجروث بليت، فهذا نعتبره انه هو سيف يصير فد هو الحد المارجن كارتليجينس بارت وما بين الكومباكت او هارد بوني بارت.
فيري جود. هذا تايب 1. تايب 2 ايش راح يصير؟
نفس الفكره مالته، بس من يوصل للايج مال بون شويه راح يكون ديفييت عنه، فيسوي لنا مثلث بشويه من الميتافيسيس، يعني مو بس ابيفيسيس، راح يكون ياخذ في التراينجل من الميتافيسيس اللي ماخذه من فوقه يعني.
ممتاز. وال3
ال3 هنا ايش راح يسوي؟ يمشي اول شيء ترانسفيرس هم على هذا المكان اللي قلنا عليه بالبدايه بالتايب 1، بس فجاه راح يدخل جوا بالبون وراح ياخذ الفيسز والابيفيسز، فبهاي الحاله ايش راح يصير عندنا؟ الجروث بليت راح هنا تتاثر، فمستقبلا ممكن يقل النمو مال العظام مال الطفل، هنا الجروث بليت ما تنضبط.
طيب والفور؟
الفور دكتور هنا راح يبدي هو الميتافيسز وبعدين الفيسز والابيفيسز، بحيث ياخذ 3 دائرات راح ياخذها.
يعني راح يصير كومبينيشن مال 3 وال2 مو صحيح؟
نعم.
والتايب اكسلنت. والفايف؟
التايب 5 هنا احنا تقريبا ما عندنا في يعني اوبيفيس فراكتشر، بس هنا شو يصير عندنا؟ يصير عندنا ديبرشن للبون، بحيث شلون نقول انه الجروث بليت انسحقت، وبهاي الحاله ايضا راح يأثر على الديفلوبمنت مال البون.
ممتاز علي، شكرا جزيلا، ممتاز. إذا Salter-House classification is a classification used to diagnose and manage fracture through the epiphyseal plate. This classification is specific for children. مثل ما قال لنا علي اكو 5 types. Type 1 passes through the epiphyseal plate. وين يدخل بين المنطقة الكورتيكال يعني بين الميتافيسيس والكارتلج، فهنا نتوقع انه there is no effect on the growth. تايب 2 نفس المسافة يمشي لكن ياخذ بعدين بيس من الميتافيسيس مثلث، يسموه هذا المثلث هولاند ساين. تايب 3 ياخذ من الابيفيزيال بليت بعدين verge to the joint. تايب 4 راح يصير combination of تايب 2 و 3، راح يجي من الجوينت ويصعد الى الميتافيسيس. تايب 5 يصير compression of the growth plate ويصير عندنا يعني الابيفيزيال بليت، ويصير عندنا هنا يسموه retrospective diagnosis، يعني طفل يوقع وبعد 3-4 سنوات نشوف صار عنده deviation، صار عنده deformity، فنتوقع انه صار عندنا compression of the epiphyseal plate وfusion بالبون، وبالنتيجه صار عندنا هذه المشكله. شكرا. قبل شوي قلنا الديفورميتي الوحيده اللي we will not accept it هو الروتيشن. من يشوف لنا هذه الصوره؟ من يشوف لنا هذه الصوره اللي علقنا عليها؟ اي بس باي انسبكشن شو نشوف بهذه مهند؟ مهند؟
السلام عليكم دكتور.
هلا مهند، صباح الخير.
صباح النور. هذه
مهند باي انسبكشن، تعرف شنو انسبكشن مو؟
نعم دكتور.
احنا بالكسور ما نقول انسبكشن، نقول لوك فيل اند موف. ان شاء الله من نبدي بالكلينيكال انا اشرح لكم هاي شلون الروتين اوف اكزامينيشن. هسه باللوك انت بتمر على هذا المريض وهذه اصابعه مسوي له هو ريفلكشن ثرو ذا بروكسيمال انترفرنجيال جوينت، يعني مسوي فيست نسميها بالطب، فيست يعني قبضه. شنو الابنورماليتي اللي تشوفها مهند؟
دكتور صاير عنده روتيشن بالبون مالته، ما صار الفليكشن مضبوط.
الروتيشن وين بياهو؟ اذا اليمين لو اليسار وبوش فينجر؟
دكتور باليمين باليسار باليمين
هن لو يمين لو يسار؟
باليمين
باليمين. خوش حكي. بيا فينجر؟
دكتور بالاندكس ليتل فينجر
ليتل فينجر. تلاحظ انه الليتل فينجر روتيتنج وبالنتيجه it will not face the other fingers. يعني هو هسه لو يسوي opposition بين الليتل فينجر والثumb ما راح يصير عنده opposition. انت هسه لو كلكم هسه كل واحد من عندكم خلي الليتل فينجر يوصل للثumb، تلاحظون انه البالم مال الليتل فينجر راح يتوخبل بالبالم مال الثumb. هو هنا ما راح يصير عنده هذه. فاذا مثل ما قلنا وراح اعيدها مره ثانيه، the only deformity اللي زيرو accepted. كل deformity اخرى ممكن نقبل 5 درجات 10 درجات 15 درجه، مرات حتى 30 درجه نقبل اذا كان طفل وعنده ريموديلينج، الا يا deformity مهند
روتيشن
very good excellent. حسن، شكرا مهند.
أهلا.
طيب هذا كلاسيفيكيشن البارحه اخذناه سميناه جاستيلو كلاسيفيكيشن. قسم يقول يسميه جاستيلو اندرسون كلاسيفيكيشن لانه هم اثنين سوا ماشي بكتابكم جاستيلو كلاسيفيكيشن. شنو هذا الكلاسيفيكيشن؟ يقدر يحكي لي عنه؟
الو نعم دكتور.
منو انت؟
مصطفى
ايش؟
مصطفى صبيح.
لا انت بس انت المصطفى بالمجموعه؟
اي نعم دكتور.
هي مع مصطفى شنو جاستيلو كلاسيفيكيشن هذا؟ يحكي عن شنو؟
كلاسيفيكيشن مال الاوبن فراكشر.
فيري جود.
نقسمهن بالمانجمنت مالته.
مصطفى عرف لي اوبن فراكشر.
دكتور فراكشر زائد ووند.
فراكشر زائد ووند. الووند هذا يا مصطفى اني ووند لو الووند بسبيشال كرايتيريا هذا؟
دكتور هو الوند at the side of fracture وتكون يعني حسب الكلاسيفيكيشن مالت الجاستيلو انه ايش قد حجم الوند وهل هو ديرتي ولا لا. نقدر يعني نسوي كفرنج.
دقيقه لحظه واحده. يعني قصدك انت انه الووند لازم يوصل الى مكان الكسر، مو صحيح؟
اي نعم.
يعني احنا اذا عندنا ووند ما واصل للكسر هذا ما يدخل ضمن الاوبن فراكتشر. فهمتوني؟
لا الوند نفس مكان الفراكتشر.
الووند اذا ما واصل للكسر، اذا الووند ما واصل للعظم هذا ما يدخل ضمن الاوبن فراكتشر. اوبن فراكتشر لازم الووند يوصل الى مكان الكسر. يعني اكو كونكشن between fracture site and the exterior. مفهوم؟
نعم دكتور.
هاي للكل مفهومه هاي النقطه. زين. عندنا جاستيلو كلاسيفيكيشن هذه اي الصوره اي. ايش تعتبرها اذا تريد تسوي لها كلاسيفيكيشن؟ ايش تعتبرها؟
اعتقد تايب 2.
تايب 2. بتايب 2 احنا ايش قلنا؟ شو يصير
عندنا يعني اللونج مال الووند اكثر من 1 سنتيم.
اي عافيه.
وسوفت تيشو انجري يكون قليل يعني مو هو مثل الباقيات.
ممكن. نعم نقدر احنا نعتبره 2 ونقدر ايضا يعني هو 2 اكثر يروح من 1. فيري جود. زين. بيش تعتبرها؟
البيناتورا تايب 3 3A.
3A والسي؟
نعم 3B.
والدي؟
الدي 3C.
3C
لأنه أكيد هنا عندنا بلاد بازل انجر.
ممتاز. كلش حلوه هذه الملاحظه. 3C طبعا الدي هو مانجلد غير كلاسيفيكيشن يسمونه مانجل سكيل، اللي هو تضطر انت ان تسوي له امبيوتيشن لو تنطيه مجال. اوكي فيري جود اكسلنت. اذا احنا عندنا تايب، عندنا 1 2 3 مو صحيح؟ وال3 بيها A و B و C، وانطاكم اياها مصطفى. فيري جود مصطفى، شكرا. اوكي انا راح اجاوب هذا فيري سمبل، هو عباره عن سكين تراكشن. سكين تراكشن هنا نخلي 2 سترابس، واحد ميديالي واحد لاترالي، اللي هو عباره عن شريط لاصق، وبعدين نلف عليهم هذه الباندج، وبعدين اكو حبل نربط به الوزن. عاده الوزن هنا اعلى وزن ممكن نستخدمه هو 4 إلى 5 كيلوات. سكين تراكشن هو عباره عن temporary way of fixation لحد ما ناخذ further steps in the management. بالاطفال قد يكون هو هذا الفاينل way of reduce and hold، لكن بالكبار عاده هذا temporary. ليش؟ لانه الاربع 5 كيلوات ما تكفي حتى تسوي لك reduction. it is a temporary way of fixation. هذا إليزاروف رينج. إليزاروف رينج نريد يحكي لنا عن هذا شنو إليزاروف رينج، هذا شنو الإليزاروف تكنيك البارحة حكينا عنه.
نعم دكتور.
ها منو؟
علي جبار.
علي جبار، يلا علي، يلا حسين. شنو فكرة إليزاروف هذا؟ شنو سوى؟
دكتور هو يعني تايب اوف اكسترنال فيكسيشن.
هذا تايب اوف اكسترنال فيكسيشن. فيري جود اكسلنت. لا الفكرة اللي سواها إليزاروف، فكرة مالت البارحة حكيناها احنا، الفكرة مال إليزاروف هي عبارة عن dislocation histogenesis. قال لك أنا من أسوي أوستيوتومي بالبون، أنا من أسوي أوستيوتومي يعني أقص البون، يعني أنا سويت كسر، مو صحيح؟ مو صحيح؟ فايش قال لك؟ قال لك أنا إذا ثبتت الكسر هذا بالاكسترنال فيكسيشن هذا اللي قدامك اللي هو مال إليزاروف اللي يصير على شكل دوائر،
راح يلاحظ كالس يعني فورميشن.
كالس فورميشن. فانا شو اقدر اسوي؟ اقدر اطول هاي الكالس، اخلي من الخارج في الديفايس معين، واظل اطول العظم. طبعا نطوله تقريبا مليم يوميه او نص الى مليم يوميه الى ان اوصل للطول الطبيعي. هذه العمليه يسموها destruction histogenesis، وهي هاي فكره تطويل العظام. يعني انا اسوي اوستيوتومي، راح تصير عندي كالس، من تبدي الكالس تتكون؟ انا راح اطول الكالس هذا يسموه destruction histogenesis. لما اطول الكالس يسموه كالوتيسيس. لما اطول الابيفيزيس يسمونه كوندرودايستيسيس. اوكي؟ شكرا جزيلا. هذا السؤال هذا بسيط جدا. من يقول لي هذا التثبيت شو يسموه؟ بس هاي هذا التثبيت شو يسموه؟ المستخدمين هنا
plate and screw.
very good excellent.
internal fixation. ها
بعد شو مستخدمين؟ هم مستخدمين plate and screw internal fixation very good. والميديال ماليولس من وياي علي بو؟
علي جبار.
علي جبار. علي علاوي. الميديال ماليولس ليش مثبتها؟ هو ما مثبتها بالبليت اند سكرو، مثبتها في شيء هيك مثل السيامه، مو صحيح؟ مثل السيمه مدخله، مو؟
نعم.
يسموه هذا؟ يسموه كي؟
نعم.
كي؟ كي واير. الكي واير هو مختصر مال كوشنر واير، فهو نقول كي واير للسهوله. اوكي؟ طيب علي وياي، هذا بيش مثبته هنا الكالكينيوم فراكشر؟ بيش مثبته؟ سكرو.
هو سكرو دكتور.
سكرو انتر فراجمنتري سكرو، مجرد براغي مدخلين وهاي. هذا شنو؟ تثبيت قبل شويه قلت لك اياه كي
واير.
كي واير فيري جود. كي واير من نشوف سيمه ملسه داخله بالعظم، هذه احنا نسميها كي واير. نستخدمه بالاطفال هوايه لانه هذا يكون نملس سموث سيرفيس حتى ما يسوي دامج للابيفيسز، لانه هذا
أنا أحب أريثروبلاست.
هل ارثروبلاستي يعني قلنا احنا مصطلح ارثروبلاستي معناها يو تشينج ذا جوينت، مو صحيح؟ هنا الجوينت احنا ما غيرنا الهيد والهذه، هذه يسمونه دايناميك هيب سكرو. دايناميك هيب سكرو
هي من ضمن عملية الأريثروبلاستي أو غيره؟
لا، الارثروبلاستي لازم تغير الراس او تغير الراس والاسيتابيولم، يعني لو تغير الهيد اوف ذا فيمر، لو تغير الهيد اوف ذا فيمر اند ذا اسيتابيولم، هذا يسموه اذا غيرت بس الهيد اوف ذا فيمر يسموه بارشل ارثروبلاستي، اذا غيرت الهيد اوف ذا فيمر والاسيتابيولم يسمونه توتال ارثروبلاستي، اذا شلت الهيد كليته يسمونه اكسجينال ارثروبلاستي او جردلستون اوبريشن. هنا الهيد موجود، فهنا هو الجراح هنا ما شال بارت من الجوينت، فلا سوى بارشل ارثروبلاستي ولا توتال ارثروبلاستي، وانما ثبت الكسر فقط بهذا السكرو اللي يسموه دايناميك هيب سكرو. هذا الدايناميك هيب سكرو هو مخصص للهيد، اسمه دايناميك هيب سكرو، يسوي كومبريشن من ينضم الديستال فراجمنت، البروكسيمال فراجمنت will be compressed with the distal fragment. اوكي؟ شكرا جزيلا. الآن نبدي محاضراتنا لهذا اليوم. Injuries of shoulder and upper arm. Quick review of the anatomy of the shoulder girdle. Girdle consists of the three bones, the clavicle, scapula, and the humerus. In clavicle, the most important part is the articulation between the clavicle and the sternum, and the other articulation between the clavicle and the acromion. The scapular part structures are the acromion, spine, conocoid process, and glenoid. Humerus, the head of the humerus, greater tubercle, lesser tubercle, surgical neck, and the shaft of humerus. Fracture of the clavicle. We have to remember that always in all fractures of the upper limbs, the most important complication that we should prevent is stiffness, because if the upper limb is stiff, it is useless. The mechanism of fracture of the clavicle is either due to fall on outstretched hand or a direct trauma to the shoulder. Special features. The fracture usually occur at the junction between the middle third and lateral third of the clavicle. As we can see in the X-ray, the outer third displaced downward by the weight of the upper limb, and the medial two-thirds are elevated, the piece of medial two-thirds are elevated up by the action of sternocleidomastoid, and this will produce a lump like in the shoulder joint, as the shoulder area, as we can see in the picture. Sometimes the fracture occurs at the lateral third, just near the claviculo-acromial joint, and this is a special type of a fracture that sometimes need interference. Comminuted fracture of the clavicle and the X-ray below. When there is multiple pieces of a fracture, multiple pieces in the fracture, this is very dangerous because it may cause injury to the underlying structures, the subclavian artery and nerve. Treatment of the fracture of the clavicle, usually conservative. Reduction is not possible, and always there is some sort of mal-reduction, and in many cases deformity is accepted. Internal fixation needed when there is non-union of the fracture, and the treatment always conservative by resting the arm in sling, an arm sling for 3 weeks, and starting early physiotherapy. In children, usually remodeling occur and no deformity will appear. Fracture of the scapula. It's very important to remember that the fracture of the body of the scapula occurs due to crushing force. So there is possibility of fracture of the ribs or dislocation of sternoclavicular joint. Fracture of the glenoid may occur due to fall on the shoulder. In X-ray, we can see either there is a transverse fracture of the body of the scapula or a fracture through the neck or glenoid, which will depress downward by the weight of the body. Sometimes there is a fracture of the coracoid or acromion can be seen. CT scan is very important when there is a glenoid fracture in order to determine the extent of the fracture and the need for surgery. Glenoid fracture sometimes treated by surgery in order to maintain the stability of the shoulder joint. Treatment reduction is not needed, and elevation of the arm in sling is very useful. In case of shoulder dislocation, we should look for glenoid fracture, and we have to take care of glenoid fracture by internal fixation if we need to do that. Acromioclavicular joint injuries. Acromioclavicular joint usually injured due to fall on the shoulder. The acromioclavicular joint usually fixed by the ligaments between the clavicle and the acromion, and the most important two ligaments between the coracoid process and the clavicle. Those are the conoid and trapezoid ligament. When there is trauma to that joint, it may cause sprain or partial tear, subluxation, or complete tear of the acromioclavicular ligaments and coracoclavicular ligaments, and this will lead to floating of the clavicle up, which will cause a bump from acromioclavicular separation appear at the tip of the shoulder of the patient. And when we take an X-ray, like the one labeled below, see the clavicle is not facing the acromion because the clavicle is elevated up. On X-ray, sometimes it is difficult to diagnose, so we ask the patient to hold 5 kilograms on each hand to see the dislocation. Treatment, subluxation usually does not need treatment, extensive treatment, just holding the upper limb and rest for 1 week and then starting physiotherapy. When there is dislocation, usually it is difficult to maintain reduction by padding, and we have to persuade the patient that this is not disabling the problem, and the surgery usually not too much helpful. But if the patient insists on surgery, we can do repairing of the ligaments in acute cases, and in all cases or untreated cases, when after a while we will excise the lateral part of the clavicle and we will fix the clavicle to the coracoid process by a screw and reconstruct the ligament artificially. Another complication may be occur is osteoarthritis, and treated usually conservative. If not helpful, we can excise the lateral part of the clavicle. Sternoclavicular dislocation. There are two types of sternoclavicular dislocation, anterior and posterior. In anterior sternoclavicular dislocation, usually the clavicle will pump forward, will migrate forward, and producing a visible mass or visible bump in front of the chest, of the side of the between the clavicle and the sternum. And this is very easy to be reduced, but it cannot be maintained at that position. This is a mild condition. It causes much more problem. Surgery is difficult here, and treatment usually to persuade the patient to accept this deformity. The posterior type is very dangerous. It is rare, but it is dangerous because the clavicle will migrate posteriorly and it will press on a very important vessels. Usually CT scan is required to see the extent of the migration of the clavicle posteriorly, and the treatment should be done by reduction of the clavicle, either by close reduction or open reduction. In close reduction, we ask the patient to lay down supine. We put a sandbag between the scapulae, and with the traction of the upper limb at an abduction position, another surgeon try to pull the clavicle up. If it is failed, we go for open reduction. Shoulder dislocation. The shoulder joint had a special problem. The shoulder consists of two parts, the head of the humerus and the glenoid. And the head of the humerus is just like a sphere, while the glenoid is shallow, so it cannot contain that sphere. In order to make it contain it, the glenoid labrum is a cartilage labrum surrounding the glenoid will contact with the head, and it is attached to the scapula. And the capsule of the joint will attach to the glenoid labrum. This labrum is useful to deepen the shallow glenoid. The muscles surrounding the shoulder joint are very important in maintaining the stability of the joint, especially the rotator cuff muscles. We have two types of shoulder dislocation according to the migration of the head of the humerus, either anterior shoulder dislocation or posterior shoulder dislocation. Anterior shoulder. There are two mechanisms for injury. First, fall on backward outstretched hand, like when somebody walking and he fall on his back, so he will use his upper limbs to avoid the fall. Or by abduction, forced abduction with external rotation that would cause the head of the humerus to migrate forward toward the coracoid process and lie below the coracoid process. The pain here is too severe that make the patient hold his upper limb with the other hand and will not permit any examination because it is too painful. As you know, all the structures of brachial plexus passing through the axilla and the head of the humerus will press on them during the mechanism of dislocation. The outer surface of the shoulder, there will be loss of the roundness of the outer surface of the shoulder, and please don't forget to examine for the nerves and vessels of the upper limb in case of shoulder dislocation. On X-ray, it is very important to remember that in dislocation there is loss of contact between the two articular surfaces. So the head will not face the glenoid will be empty, and the head will be located inferior and medial to the glenoid. And this is the most important clue for diagnosis of anterior shoulder dislocation. the head of the humerus will be located below and medial to the glenoid. Treatment: it is very important to give the patient sedation because it is very cause neurogenic shock. In case of recurrent shoulder dislocation, sometimes the patient had his own trick to reduce the dislocation, or the doctor can reduce the dislocation without general anesthesia. But in case of first attack, it is wise to use general anesthesia. Treatment: there are many methods used to reduce the shoulder and anterior shoulder dislocation. While waiting for doing the maneuver, we can ask the patient to lay prone position, that picture A, and holding the weight by his arm, so it can be reduced spontaneously. In B, we can see another method. This is called the Hippocratic method, asking the patient to lay down on the ground and the surgeon put his foot and the axilla while he is trying to pull the upper limb over him and using his foot as a lever to reduce the dislocation. In the other picture, we can see another method by method, and I hope that in clinical session we can teach you all these methods. It is wise to remember that after reduction of the shoulder dislocation, we have to put the arm in an arm sling, and we have to fix the shoulder, prevent it from movement. And this should be kept for 3 weeks when the patient below 30 years. Why? Because the possibility of recurrent dislocation. And those patients who are above 30, usually stiffness is a problem. So no need to keep the patient for 3 weeks immobilization, just 2 weeks, and then we start for 10 days, and then we start physiotherapy. Complications: nerve injury. Usually the axillary nerve is injured, and in this condition we see the patient cannot use his deltoid muscle, and there is anesthesia over the upper lateral aspect of the arm. Or sometimes there is injury to the posterior cord, which will cause damage to the nerve injury to the median nerve and musculo-skeletal nerve. All these nerves injury are of neuropraxia type, which is a temporary injury, and it will heal spontaneously. Vascular injury, fracture dislocation, and recurrent are other complications. Posterior shoulder dislocation. Posterior shoulder dislocation has a special problem: it may be missed. The mechanism of injury is either forced abduction and internal rotation, or epilepsy, electrical shock, or direct trauma to the shoulder joint. Why it is missed? Because the X-ray look normal, the head facing the glenoid. But clinically, we can diagnose posterior shoulder dislocation by examining the upper limb. The patient will keep his upper limb internally rotated, and he cannot do external rotation. This is very important clinical sign. Whenever a patient came to you and his upper limb is internally rotated and he cannot do external rotation, this is an indication for posterior shoulder dislocation. When you take an X-ray for the patient, you may see that the head facing the glenoid. But because it is internally rotated, the greater tuberosity, lesser tuberosity will facing you directly. So the head will look globular in shape. We call it elliptical bulb appearance. And in order to be more sure about the diagnosis, you can take lateral X-ray to see that the head away from the glenoid. Treatment reduction is important by pulling the arm and externally rotated while another surgeon pushing the head forward. And the upper limb should held in arm's length for 3 weeks. Recurrent dislocation. Recurrent dislocation occurs when the stability of the joint affected by the dislocation. In shoulder, usually the anterior is more than posterior, but it is difficult to diagnose whether this is an anterior, recurrent anterior or recurrent posterior, because it usually the patient will come after reduction. So it is important to look for the signs of recurrent anterior shoulder dislocation. This is by asking the patient about the mechanism of injury. Usually, the patient cannot, when he uses his upper limb and abduction, external rotation, it will cause the dislocation, like when he wants to put on his clothes or using his arm above his head or during swimming. And the apprehension test will be positive. Apprehension test by asking the patient to do abduction, external rotation, and while extending the upper limb, the patient will become apprehensive. In X-ray, we can see a Helsach lesion. Helsach lesion is a depression at the upper lateral aspect of the head of the humerus, around by the sign, due to the recurrent impingement with the inferior glenoid wall. And there is another lesion, we call it anchor lesion, due to the avulsion of the glenoid labrum. This can be diagnosed by CT and MRI. Treatment of recurrent shoulder dislocation, anterior shoulder dislocation, if there is need for surgery when the dislocation affecting the activity of the patient, or it become recurrent that make him cannot do his sport, we may do a reconstruction of the anterior capsule and reinforcement of the anterior capsule, which will promote healing. Fracture of a proximal humerus. Usually this fracture occurs in old age patient, osteoporotic bone, due to fall on the outstretched hand. And the fracture usually occurs through the surgical neck, and so there will be two parts, the head and the rest of the bone, and one of the two tuberosities, the greater or lesser tubercles, may be fractured. The pain sometimes is not so severe because the fracture is impacted, but after 1 or 2 days, there will be a big bruise extended up the arm, indicate that there must be a fracture. And when X-ray is taken there will be show a single impacted fracture in old age. In younger age, the fracture lines appear more clearly. There is a special classification, near classification to diagnose and treatment of this fracture. In one part fracture, the fracture is impacted, so the humerus appears as a one piece. In two-part fracture, there is a fracture that passes through the surgical neck and head, and the rest of the bone are separated, or one of the tuberosities, greater tuberosity, greater tubercle, or lesser tubercle. In three-part fracture, the head, there's a fracture through the surgical neck, and one of the tubercle may be separated, either the greater or the lesser. In four-part fracture, there is a fracture through the surgical neck and separation of the greater tubercle and lesser tubercle. This may look easy to diagnose, but usually this is very difficult, so we need multiple view X-ray in order to diagnose the extent of the fracture and the pieces of the fracture. Axillary view, lateral view, anterior, posterior, all of this are needed, and sometimes we may need to do CT scan in order to achieve the diagnosis. Treatment for the part 1 fracture, treatment is conservative by holding the arm in sling for 3 weeks, and after that we start physiotherapy. In two-part fracture, we achieve reduction, close reduction first, and then we go for harvesting and conservative treatment. In the three-part fracture, open reduction and internal fixation is necessary. In four parts fracture, because of the debridement of the head blood supply, so there will be a need for arthroplasty, either partial arthroplasty or total arthroplasty. The complications, fracture dislocations, especially if the fracture is too extensive, and if there is subluxation or dislocation of the shoulder joint, vascular and nerve injury, and stiffness. Fracture of the shaft of the humerus. A fall on the hand may twist the humerus, causing a spiral fracture. A fall on the elbow with the arm abducted may hinge the bone, causing an oblique or transverse fracture. Direct blow to the arm will cause a fracture which is either transverse or comminuted. Fracture of the shaft in an elderly patient may be through a metastasis. Special feature, the arm is painful, bruised and swollen. Active examination of the wrist and finger should be tested before and after treatment because of the radial nerve may be damaged. X-ray, the fracture is usually obvious, but don't forget to look for features suggesting pathological lesion like fracture through aborsis or metastasis. Treatment. Fracture of humerus requires neither perfect reduction nor total immobilization. The weight of the arm with an external cast is usually enough to pull the fragment into alignment. The cast is applied from the shoulder to the wrist and the elbow flexed 90 degrees held for 2 to 3 weeks. If the fracture is very unstable and difficult to control, then open reduction, internal fixation is required. In case of pathological fracture, also ortho reduction and internal fixation is a good choice. Complication, nerve injury, especially the radial nerve, by checking for the metacarpal for the wrist joint and paralysis of the metacarpophalangeal joint extension. Usually the type of injury is neuropraxia, and there is a recovery expected after 12 weeks. If there is no recovery, exploration of the nerve is required. If the injury to the nerve occurs after reduction, it indicates immediate exploration. Medial nerve also may be injured. Non-union mid-shaft fracture, sometimes felt to unite. This is treated by bone grafting and internal fixation. استراحة لمدة 5 دقائق. Fracture of the distal humerus in children. Epidemiology. The elbow is the second only to the distal forearm for frequency of fracture in children. Most of these injuries are supracondylar fracture. The remainder are condylar, epicondylar, proximal radial, and ulnar fracture. Boys injured more than girls, and 1/2 of the patients are under the age of 10 years old. The usual accident is a fall directly on the point of the elbow or fall on outstretched hand. Pain and swelling are often marked, and examination is difficult. The most important thing is to know the carrying angle. The carrying angle with the elbow extended, the forearm is normally in slight valgus in relation to the upper arm. The average carrying angle in children being about 15 degrees. Bowman's angle, anteroposterior AP view are sometimes very difficult to make out, especially if the elbow is held in flexion after reduction of supracondylar fracture. Measurement of Bowman angle is helpful. This is the angle subtended by the longitudinal axis of the humerus, humeral shaft, and a line through the coronal axis of the capitellar physis. The angle should be not less than 80 degrees. If it is more than 80 degrees, it indicates varus deformity. Supracondylar fractures. This is a very common injury in children. The distal fragment may be displaced either anterior, posteriorly, or medial or lateral, and sometimes it is rotated. Posterior displacement is the most common type. The cause of injury is fallen on outstretched hand or on the tip of the elbow. The jagged end of the proximal fragment hooks onto the soft tissue anteriorly and sometimes will cause injury to the brachial artery and the median nerve. Anterior displacement is rare and because of bone reduction. Special features. swelling on fall, the child is in severe pain and elbow is swollen. When there is posterior displacement, as deformity will be appear. It is very essential to examine for pulsation and check capillary return. X-ray and displaced fracture usually missed by the X-ray, but there is soft tissue swelling and edema with sometimes hematoma formation. In posterior displacement, the distal fragment is tilted backward and or shifted sideways. In the anterior displacement, the displaced piece are tilted forward. Checking for omen angle is very important to check for the varus and valgus angulation. Treatment. Even if there is suspicion of a fracture, it is wise to put the elbow in splint for a 30-degree of flexion to prevent movement until rechecking by the X-ray and check for neuromuscular problem. In any displaced fracture, usually the elbow is immobilized at 90 degree and neutral rotation, and we have to re-X-ray after 5 to 7 days, and in 3 weeks the problem is settled. Posteriorly, when the displacement is minimum, usually swelling is not too much, and we have to reduce the fracture under general anesthesia by a 3-step maneuver, traction for 2 minutes with counter traction on the longitudinal axis of the arm, correction of the sideways tilt, and the gradual flexion of the elbow to 100 degree while pushing the polycranial by the thumb. After reduction, we have to check for the pulse and check for capillary return. If there is suspicion of circulatory impairment, we have immediately to relax the amount of elbow flexion until the circulation improved. X-ray should be confirm reduction, and moment angle very important to be measured. If reduction is unstable, we may need to put K-wires, percutaneous cross K-wires, Kirchner wires. After reduction, the arm is followed up, especially in the first 24 hours for possibility of circulation impairment, and X-ray after 3 to 5 days. Usually the fracture will heal within 3 weeks. Posterior displaced fracture, if there will be a severe swelling, the possibility of vascular injury compartment syndrome is very common, and treatment by crossed reduction under GA with either open or closed, and fixation of fracture by crossed K-wires. Anteriorly displaced fracture, this is due to over-reduction of posterior displaced fracture. It's reduced by traction on the longitudinal axis of the arm, and then pressure by the thumb on front of the elbow to reduce the fracture. Posterior slab split, follow-up of the circulation, and healing by 3 weeks. Complication, vascular injury. The great danger of supracondylar fracture is injury of the brachial artery. The peripheral ischemia may be immediate and severe, but sometimes pulse may be failed to return after reduction. And edema is one of the complications which may lead to compartment syndrome, which lead to the necrosis of the muscles and nerves within the compartment. If the baby has severe pain, plus one positive sign, pain on passive extension of the finger, tense and tender forearm, absent pulse, blunt sensation, or reduced capillary feeling, return on pressing on the finger palm, this demands urgent action. The flexed elbow must be extended and all dressing should be removed. If circulation does not improve, we must do angiography. And we must prepare for surgery if there is damage to the artery. If angiography is not available, Doppler is wise to be used. Nerve injury, median nerve injury, and we suspect healing within 6 to 8 weeks. Malunion is very common because of the distal fragment may be shifted, anterior, posterior, medial, and lateral. And the most common is the cubitus varus, less commonly cubitus valgus. Elbow stiffness is another complication, but it may take a while to return back to normal, about a few months. Angio pain plus one positive sign, pain on passive extension of the fingers, tense and tender forearm, absent pulse, blunt sensation, or reduced capillary return on pressing the finger palm, demand urgent action. The flexed elbow must be extended and all dressing are removed. This slide is very important. It summarizes the action of the doctor when he faces a problem of circulatory impairment with the supracondylar fracture of humerus in children. Fracture separation of the lateral condyle. If the child falls with the elbow stressed into varus, there will be a large fragment including the lateral condyle can be avulsed by the attached wrist extensor. The fracture line usually runs along the physis to enter the joint through the trochlea or less often through the capitello-trochlear groove. The types of the fracture according to the Salter-Hals classification, either type 2, which is the more common, and type 4 is less frequent. Usually the fracture is larger than it would appear, and if the fracture runs through the trochlea, the elbow joint are dislocated, the fragment may be grossly displaced and capsized. Treatment, if there is no displacement, treatment is conservative bisplinting. If there is, and check for the reduction after 1 week, after 2 weeks, and if the fracture is displaced, trial of reduction. If closed, if we failed, we go for over-reduction internal fixation by KORs, and the most common complication is non-union and malunion because of the condyle may be left capsized. The possibility of non-union is inevitable. With the growth, the elbow become increasingly into valgus and ulnar nerve palsy may be occur. Malunion likewise can result in cubitus valgus. If deformity is marked, it should be corrected by supracondylar osteotomy. Recurrent dislocation of the elbow, condylar displacement result in recurrent posterolateral dislocation of the elbow. The only effective treatment is reconstruction of the bony and soft tissue on the lateral side. fracture separation of the entire distal humeral epiphysis. This is a condition occurred in children below 7 years. This fracture, just like the supracondylar fracture, in all aspects and treated accordingly. Also same complications and same problem with vascularity and nerve injury. Separation of the medial epicondylar apophysis. If the wrist is forced into extension, the medial epicondylar apophysis is repulsed by the attached wrist flexors. If the elbow opens up on the side, the epicondylar fragment may be pulled into the joint. The fractured piece are shown in the X-ray, labeled with red arrow, and in the other X-ray, the fragment, the medial epicondylar apophysis enter inside the joint, and it has been followed by the blue one. The joint becomes swollen and very tender. Treatment: if there is a minor displacement, the treatment is conservative. If there is severe displacement more than 2 to 3 centimeters and cannot be reduced, or the fragment trapped inside the joint, open reduction and K-wire fixation is enough. Please remember this X-ray. Number 1 is the humerus, 5 capitellum, 6 radius, 7 head of the radius, 8 ulna, 9 olecranon, 10 coronal process, 11 this is shadow of the fat. Fracture of the distal humerus in adults. Types: the fracture either extra-articular supracondylar, like in A, or intercondylar unicondylar, like in B, or intra-articular bicondylar in C. The supracondylar fracture in adults are rare, usually comminuted, and it's very difficult to hold it with conservative, and it needs open reduction internal fixation. Condylar fractures in adults, usually this is a severe injury caused by extensive force, except in osteoporotic bone. The olecranon driven up and causing the fracture. Fracture might extend it to one condyle or both condyle, and it may cause a comminution of the entire distal part of the humerus. The X-ray is sometimes difficult to evaluate because the possibility of fracture would not appear, so multiple view and CT scan may be required. Treatment: if the fracture is undisplaced, it can be treated conservatively, but follow-up carefully should be done because of the possibility of reduction. In displaced fracture, usually open reduction internal fixation, and fixation with K-wire usually not sufficient, so it needs multiple screws and plating. Complication: vascular injury, brachial artery and compartment syndrome. Nerve injury, median nerve, ulnar nerve could be affected. Stiffness is a common complication, and heterotopic bone, heterotopic ossification. Fracture capitellum. This fracture occurs only in adult. The head of the radius will push up the capitulum, causing it to fracture. The fracture of the capitula will appear easily if you take lateral X-ray. But if it is difficult, if there's difficulty in diagnosis, CT scan is advised. The treatment, if the fracture is displaced, conservative treatment may be advised. If it is displaced, open reduction, internal fixation by bird screw if it is large, if it is small, and or community excision of that piece is advised. Dislocation of elbow. A fall on the outstretched hand may dislocate the elbow. 90% of cases, the direction of dislocation is posterolateral for the forearm falls. Reduction usually stable if there is no fracture dislocation. Special features, deformity is usually obvious, and usually there will be a severe pain, swelling, and there's difficulty in examining the elbow. The hand should be examined for signs of vascular or nerve damage. X-ray is important to confirm diagnosis and to identify any associated fractures. Treatment in undisplaced and uncomplicated dislocation. In case of uncomplicated dislocation, the patient should be fully relaxed under anesthesia, and the surgeon pull the forearm while the elbow is slightly flexed, then correcting sideways displacement with the other hand, and pushing the olecranon by the thumb forward while flexing the elbow, checking for the reduction by flexing and extending the elbow fully. After reduction, we have to check for the nerves and vascularity of the hand. The arm is held in light cast at 90 degree and with the support, collar and cuff, and after 1 week the cast can be removed and gentle exercise begin. 3 weeks collar and cuff should be started. There is a fracture dislocation called terrible triad when the radial head coronal process are fractured with damage of medial collateral ligament. This needs open reduction and internal fixation with reconstruction of the medial collateral ligament. Complication, vascular injury, nerve injury, medial nerve, ulnar nerve, stiffness, heterotopic ossification, osteoarthritis. Pulled elbow. In young children, the elbow is sometimes injured by a sharp tug or on the wrist. The child is in pain, the elbow is held in extension, and he will not allow it to be moved. There are no X-ray changes. What was happened is that the radius has been pulled distally and the annular ligament has slipped up over the head of the radius. Treatment, forcefully supinating and flexing the elbow. Fracture of the proximal end of the radius. This is common injury, especially in young adult children, due to fall on outstretched hand. In adult, the head is fractured, but in children, most likely the fracture passed through the neck of the radius. The articular cartilage of the capitella may be involved. The special features, there will be severe pain, local tenderness, posterolaterally, and there is pain in pronation and supination of the forearm. X-ray in children, the fracture passing through the neck and the head is tilted forward and outward. In adult, there is vertical split of the head usually. Fracture through the neck is rare, and crushed or comminuted fracture is another type. The wrist should be examined very carefully for the possibility of injury of the distal radioulnar joint, which is called Essex lopresti lesion. Treatment in children, the fracture of the radial neck tilting up to 30 degrees and radial head tilted for 3 millimeters of the transverse displacement are acceptable. Coronal cuff is enough. If displaced more than 30 degrees, we would do close reduction by pressure or by thumb under general anesthesia. If it is failed, we go for open reduction internal fixation. The head of the radius must never be excised in children because it will lead to interfere with the synchronized growth of the radius and ulna. In adults, displaced fracture can be treated conservatively by using coronal cuff for 2 weeks. In displaced fracture, usually open reduction and internal fixation is required. Comminuted fracture, in past we do excision, but nowadays there is an artificial prosthesis to replace the head because this will cause the proximal migration of the radius and affecting the distal radioulnar joint. So it is wise to put a prosthesis when there is a comminuted fracture of the head of the radius. Complication, stiffness is a common, recurrent, instability of the elbow and osteoarthritis. Fracture of the olecranon process. There are 2 types of fracture of olecranon process, either comminuted or transverse fracture. Those fractures occur due to fall on the tip of the elbow. When there is a transverse fracture, the triceps mechanism is affected. In comminuted time, the triceps mechanism is still active. And special features, there is bruises over the area and there is pain and swelling. The X-ray show either displaced fracture, transverse displaced fracture, or transverse and displaced fracture, or a comminuted fracture. Treatment, comminuted fracture can be treated conservatively, but usually it ends with thickness. And double fixation may be advised. In spite of that, it is very difficult. In undisplaced fracture, in transverse type and displaced fracture, we can treat the patient conservatively and by putting the elbow flexed 60 degrees and put cast posteriorly and wait for 1 week, then starting gradual exercises. In displaced fracture, usually treatment is open reduction in terminal fixation by circular wire or glenoid or screw. The complication, stiffness, non-union, and osteoarthritis. Thank you very much. أكو سؤال؟ طيب ناخذ استراحة لمدة 5 دقائق ونكمل.